This is Carly Simmons, and this is my Unit 4 Case Connections presentation. I am only redoing the last case, or the last scenario on case 2 because my video just keeps messing up and it keeps freezing, so I'm inserting another recording into this one and will only be going over the last scenario in case 2. Okay. A 4-day-old infant is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy and birth via vaginal delivery were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6 milligrams, and the normal range is typically 1 to 2 milligrams. As previously stated, the patient had an increased phenylalanine level, indicating that phenylalanine is not being converted into tyrosine. Therefore, the most likely enzyme that is deficient is phenylalanine hydroxylase. This enzyme is essential for the conversion of phenylalanine to be converted into tyrosine, and a deficiency in PAH can result in phenylketonuria disease. This is consistent with no other symptoms besides elevated phenylalanine levels, as newborns can appear normal, with symptoms showing up several months later. In this case, tyrosine becomes essential as a result of the PAH deficiency. Treatment and management of this deficiency can include dietary regulations to control low phenylalanine levels and ensure there is enough dietary intake of tyrosine. There is no adequately supported research that suggests vitamin supplementation helps with PAH deficiency. Hello, my name is Carly Simmons, and this is my presentation for the Unit 4 Case Connections. So for case 1, a newborn girl appeared normal at birth, but within 24 hours, she developed lethargy, hypothermia, and apnea. The attending physician suspected a metabolic disorder and ordered a full panel of blood work. The blood work was ordered, and the data for this female is presented below. The initial blood ammonia level was elevated at 314 and rapidly rose to 600. Further analysis shows urine orotic acid levels were markedly elevated at 473, and the plasma citrulline level was normal at 10. Amino acids play a role in the movement of ammonia, and they initially undergo a transamination reaction, which transfers the nitrogen from a keto group to an amino group. This reaction requires an aminotransferase, such as aspartate aminotransferase, and this enzyme requires pyridoxal phosphate as a cofactor. These enzymes will transaminate with alpha-ketoglutarate, which can then be used in a deamination reaction to produce glutamate. Glutamate dehydrogenase is used in transamination reactions to fix or free nitrogen. When glutamate undergoes a deamination reaction catalyzed by glutamate dehydrogenase, ammonia is freed. The glutamate that results from deamination by GDH can transaminate with OAA to produce aspartate, which can then enter the urea cycle and can be used in the production of urea. Another key enzyme is glutaminase, which can free ammonium to enter the urea cycle and be excreted in the urine. In the fasted state, there is no dietary intake of glucose to be used as a source of energy, and as a result of this, the body must use alternate sources like fatty acids and amino acids to maintain the blood glucose levels. Gluconeogenesis is a process of producing glucose by using glycerol, lactate, pyruvate, and glucogenic amino acids as substrates. Amino acids can then enter gluconeogenesis via the citric acid cycle, and then they are broken down in this cycle into alpha-ketoglutarate, succinyl-CoA, and fumarate. The substrates produced are converted into oxaloacetate, which is an essential substrate used to produce the enzyme PEP carboxykinase, which is required in gluconeogenesis. The elevation of urine orotic acid levels indicates a deficiency in the urea cycle or in pyrimidine synthesis. This is due to excess carbamyl phosphate from the urea cycle being shunted to the cytosolic pathway. This then increases flux through pyrimidine synthesis, causing elevated levels of orotic acid. Or there can be a deficiency in the enzyme orotate phosphoribosyl transferase, which is essential in pyrimidine synthesis. In this patient, there were also elevated levels of ammonia in the urine, indicating that this is most definitely a urea cycle deficiency. If there was an orotate phosphoribosyl transferase enzyme deficiency, ammonia levels would not be elevated, and this would be a deficiency in pyrimidine synthesis. The most likely enzyme deficient in the urea cycle is ornithine transcarbamylase, which is essential for combining carbamyl phosphate and ornithine to produce citrulline. A deficiency of this enzyme would lead to an accumulation of carbamyl phosphate, and in cases of excess, as stated previously, would be shunted to the cytosolic pathway to stimulate pyrimidine synthesis. During pyrimidine synthesis, orotic acid is produced as an intermediate and is excreted in the urine. In this patient, the citrulline levels were also slightly decreased, indicating that there is a decrease in production of citrulline due to the deficiency in OTC. Because of the deficiency in OTC, ornithine and carbamyl phosphate are not being combined to produce citrulline, leading to the decrease. It is not likely that there is a deficiency in arganosuccinate synthetase, which is essential to adding the second amino from aspartate and combines with citrulline to produce arganosuccinate. In this case, there are no amino acids that become essential as a result of this deficiency. For case 2, scenario 1, a full-term girl was born by normal vaginal delivery and then was released from the hospital at 3 days of age. At 9 days of age, a screening test for branched-chain amino acids came back positive and the child was readmitted to the hospital for further evaluation. There was no history of any genetic disease in either family and both older siblings were well. The most likely enzyme deficiency in this case is branched-chain alpha-keto acid dehydrogenase complex, as this enzyme is required to break down the 3 branched-chain amino acids. A deficiency in this enzyme can cause a deficiency in metabolism of the 3 branched-chain amino acids, resulting in the presentation of maple syrup urine disease. It is not likely there is a deficiency in pyridoxal phosphate, as this enzyme is required for all transamination reactions to remove the NH3, which is an essential step in all amino acid metabolism. There are no amino acids that become essential as a result of a deficiency in this enzyme. Treatment of this deficiency is supplementation of vitamin B1, also known as thiamine, which can help with the enhancement of residual enzyme activity. So in this case, the deficiency of branched-chain alpha-keto acid dehydrogenase complex, there is still residual enzyme activity, and the vitamin B thiamine would help with the metabolism of the 3 branched-chain amino acids, which include isoleucine, leucine, and valine. For case 2, scenario 2, a 69-year-old woman presented with a 30-year history of lower back and large joint pain in the hips and in the shoulders. On further examination, blue-gray pigmented macules were present over the cartilaginous portions of the ears and on the sclera. Past medical history also included aortic stenosis. As already stated, the patient presented with a history of lower back and large joint pain and pigmented macules on cartilaginous portions of the ears and on the sclera. These symptoms are consistent with a disease known as alkaptonuria and is a result of a deficiency of the enzyme homogentisate 1,2-dioxygenase, or HGD. In addition to these symptoms, the patient also has a history of aortic stenosis, which is consistent with alkaptonuria or deficiency of homogentisate 1,2-dioxygenase. This enzyme is a part of the metabolism of tyrosine, and as a result of this deficiency, there is a buildup of homogentisic acid. No amino acids become essential as a result of a deficiency of this enzyme. Treatment and management of this disease can include vitamin C supplementation, which can slow the accumulation and deposition of homogentisic acid. For case 2, scenario 3, a 4-day-old infant is being followed in your clinic. Her birth weight was 5.9 pounds, and the pregnancy at birth via vaginal delivery were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6 milligrams, and the normal range is typically 1 to 2. As already stated, the patient had an increased phenylalanine level, indicating that phenylalanine is not being